So today I'm going to be presenting about essentially Nigerian men's mental health. So this is a little bit of a non-specific thing to talk about because it's very broad. What does that really mean? Are we talking about men in Nigeria versus immigrants that came over here versus people born in Nigeria versus younger versus the older generation? So to give you some background about me, I'm an immigrant. I came here at 7 years old to America from Nigeria. So I wasn't born here, but I was pretty close, right? That's kind of the time period when I started gaining, let's call it consciousness. So the other question you might be thinking about is why are we looking at immigrant men from Nigeria in particular? So honestly, there's very little research on this topic. And while it's a good question, if I'm being honest with you, it kind of contributes to you can think about it from all immigrant men's perspective because the same issues that Nigerian men face as immigrants are the same thing that most other immigrant men face as well. So often it's the similar stereotypes and upbringings. So there's a lot of overlap with those other populations, including the emotional suppression, including a lot of emotional suppression, the pressure from being the having the provider role because there's a lot more traditional roles that are enforced and thought about. A lot of kind of stoicism mentality, stoicism being equaling masculinity in these households, especially for Nigerian men. So again, as part of why we focus on Nigerian men in particular, so there's been rapid growth of Nigerians worldwide across the board, not just here in America, but in the UK and other countries, a lot of, let's call it the West, but all countries really, right? So there are almost 400,000 first and second generation individuals in the US alone. On top of that, Nigerians are often among the most educated immigrant groups. Almost 30% hold a master's, PhD, or PhD plus degree, compared to 11% of the US population, often in sectors like healthcare. I'm obviously a physician talking to you all, technology and academia in any capacity. That being said, that on its own has its own issues, right? There's a lot of stress that comes with that. And then there's also the concept of coming from another culture to a place that you don't understand, kind of the migration stress. So even though this presentation is focused on Nigerian men, there are also like women also obviously Nigerian women have their own difficulties with some variations, similar issues, but some differences just based on tradition. So one big one is the dual identity conflict. How, you're trying to be Nigerian at the same time as going to another country and thinking about how to integrate into that country. You're leaving all your friends behind, your family, and the way you approach life in Nigeria may not be the same way you approach life in, for example, I moved to Seattle, Washington when I came here. It's not the same way you approach life there versus here in Texas. So you had a way of living life in Nigeria. So all the social capital that you gained when you were younger back there is different here. You don't have that social capital in the new country. And the way Nigerians think about anxiety and depression may not line up the same way they do over here in the US. Often distress may be thought as more just irritability, social withdrawal, and hyperfixation on work, which standard screenings that are done here in the US may not cover, such as like the PHQ-9, which we use a lot. One of the biggest things that his Nigerian men is kind of the pressure to assimilate versus preserve culture. Thinking about how much you want to keep up your Nigerianness versus how much you have to, not necessarily always want to, but have to integrate in a different culture. Then when you go to a new place, understanding new social nuances, while you're thinking about maybe if you have children over here, are you going to be able to teach your children the home language? While in some cases, do they understand English? Are you teaching them English? And if so, how? Are you just going to let the school system do it? Or are you going to do both school system and teach them English yourself as well, while dealing with all the other issues that you have to deal with just as a part of daily life? And at the same time, thinking about if you're going to teach them the home languages, is that something you're going to be teaching and doing at home? Um, Often, this like all these stressors kind of come all at the same time, and there's not always an automatic answer. So you have to think about that. And then on top of that, you're in a new country, so outside of the social barriers, it's hard to understand a new system. It takes time. Nothing's automatic. So even when it comes to mental health, what does that mean? So insurance may be a new thing to think about and how you're going to approach cost of insurance and just cost in general. So like I'm saying, so it's very difficult. Like, good luck getting a Nigerian man to spend money on mental health. So without insurance, a single psych intake for a full evaluation can cost anywhere from $300 to $500, depending on where you are and who is doing it. For someone who's just come to a new country and is working very hard, this may constitute several days of labor, which is not something that's going to be, and like your typical Nigerian man is going to be willing to give up like for something he doesn't consider very important. And then, of course, there's the hidden costs of taking time off to take care of your mental health, which includes if you're taking time off, that's time off that you could be working. So that's money, that's an opportunity cost of money. And then if you're taking time off to go somewhere, that's transportation costs, whether it's gas or subway, bus, whatever. If you have children, which many do, how are you going to handle that? Lack of childcare. And then there's also the part where, as someone who's coming to a different country, you are doing your best to assimilate and to pretty much not stand out. You want to fit in with the crowd as much as possible. So there might be visa issues you're thinking about or that are still in process. The last thing you want to do is stand out in any regard that may inhibit that process from continuing normally. So, along with all the costs, there's also the fear of just pretty much any of your issues being known, broadly speaking, not just on a social level, but on an institutional level, right? Is the visa office going to know about your health issues or mental health issues? And if so, will that impede your path to citizenship or whatever goal you have in the country? And then, of course, there's lack of representation in the mental health workforce in any capacity, but especially mental health. So only 2% of psychiatrists in America are Black, only about 30% of these being male. Nigerian or specific Nigerian stats are actually unknown. So like very few papers, like I mentioned before, even talk about these kinds of things. So there's only a few that do, and these are the stats from those. Now, I'll be talking about Nigerian men, but if I'm being honest with you, everything I just said also applies to people who were born in America, including like the mental health issues for what other things they're applying from an institutional perspective, right? So imagine applying to medical school or residency from my perspective. Is this something that you'd want the your school or your future job to know about? The answer to that is almost always no. So similar things apply to Nigerian men, of course, except they think about it much more, and the stressor is much more abundant for them, and could potentially have higher ramifications. And then, of course, the immigrant experience in general is just tough coming to a different country. So you're leaving home, the way you think about yourself and how you live life is going to change completely. There's the And it just by itself, being an immigrant already has its own mental health stressors. So there's the stress of visa issues. What does that mean? Visa, are we here just to work? Are we here to live? Maybe forever? Are we here to live and then go back? It's a new country. That often means that you've left your work employment wherever you were from, or in this case, Nigeria, of course. So now you're here. What does that mean financially? Some people do come here and they're very wealthy, so that's not an issue for them, but many don't. And in a lot of cases, and this is probably a really big one that is not always talked about or thought about, is once you do start working here, it's not a matter of just providing money for yourself. It's also sending money back home. So that's its own stressor. And Nigerians tend to be, oh, I'm sorry, Nigerians actually tend to be really, really social at baseline. That being said, that if you're going moving to a new country, you're leaving all your friends, family, your social capital at home in Nigeria. So now you're moving to a new place where you don't know anyone, and it's a lot harder to like, make friends and be in understand the social environment when everything is really different from what you're used to. So you have to learn how to navigate this new place. And just because you don't have the same social capital in a new place, you have to, of course, learn and talk to people and think about how everyone else now behaves in this new place. So there's a lack of emotional vocabulary in terms of how Nigerians think over here and what they talk about, or more importantly, when it comes to mental health, what they don't talk about. We often don't talk about it at all, right? We all have our issues and then we just kind of push them in one corner and don't talk about it at all. With Nigerians, there's often a lot of others have it worse mentality, especially coming from Nigeria, where a lot of things can be bad or very difficult. So it's well, it could be worse over here in Nigeria, doing something else. There's maybe less stressors in some capacity over here. So therefore, others have it worse. So therefore, like, I'll survive. I'll be fine. I don't need to worry about it or think about it. And another thing that Nigerians love to do is when there's additional stresses, all that means is just work harder, right? So there's a lot of overworking, pushing yourself to another limit. Um, and all of these are coping skills, or well, skills more like coping mechanisms. Not everything's skill in this regard. They also, a lot of Nigerians are very religious, so they often look towards religion in the community and look towards going to church or mosques. Mm, And unfortunately, there's often a spiritual framing of illness, things like, well, like, oh, if I have mental health issues, that's because like there's a spirit that's possessing the person or is affecting me. So I can pray it away, which you cannot. So like kind of as part of that, barriers to cure. In Nigeria, often a lot of things like psychosis are thought of from a madness perspective. Like it's called literally called madness. So they'll just stigmatize it by calling it madness. And all that does is when someone is experiencing anything, let's say someone's hearing voices or is unable to concentrate because of various hallucinations, that's scaring them, to be honest, they're going to have a very hard time disclosing these symptoms honestly to anyone. And like I said before, with the coping, there's a lot of kind of self-talk where it's like, well, depression isn't real. So, other people can suffer and say these and those things, but it can't affect me. So depression isn't real. And they won't think about it as something that's can actually affect them or that can affect others. And like I mentioned with kind of prayer can have its positives, but often if that's all someone's looking for certain mental or health issues in general, but especially mental health, and if they believe that it's a prayer thing that, you know, they could be whether it's possessed or anything like that, they may look towards prayer over psychiatry. And then in general, like when it comes to Nigerian men, there's a lot of, like I said, kind of machismo, masculinity, stoicism that's associated with being a Nigerian man. So anything that presents you in a lesser version of yourself, or that makes it seem like like you're weak, that's terrifying, directly or indirectly. And that makes it hard to look for something that will help you out. Definitely not a psychiatrist in general. And of course, you're in a new place. There's already a million and one stereotypes about the medical system. It's at this current time, there's already like a lot of distrust of the medical system. There was a lot of distrust previously, some of it warranted, but with the baseline distrust of the system and all that combined with the stigma, the preference for private psychiatry, fear of weakness. So the system's already hard to trust that baseline with all these together, there's just so much that's impeding the potential to get better. So I've talked a lot about issues now. What are things that might help? So a lot of things that involve the community where people feel like they're associating and talking with other people, social things, um, is a big one. And the good news is Nigerians are everywhere. I want to say Nigeria is the 12th. I could be wrong on this. The 12th largest nation by population in the world. And literally every country that you go to, you find some Nigerians. And from the US perspective, every city that you go to, you find Nigerians. And therefore, that means you find Nigerian associations. Some associations are just like city level or state level, even state level in Nigeria, right? So there's various associations everywhere. All you have to do is look, send an email, call, you'll be able to find something. And that tends to help just having people around you that are similar, that can help you integrate, that can help you think and talk about some of these issues. And then this is something, I mean, well, Nigerian men just don't do this very much. Is sometimes just taking the time to relax and enjoy some of the things that you like. Yes, you're in new places, a lot of new stressors, but mental health is multifactorial, meaning there's not always one cause. We're trying to always, as human beings, we're looking for that one thing that we can change, that one magic pill, one magic bullet. But there's a lot of different things that can affect our mental health. So, yes. And before you even look for someone like me or a therapist or a counselor, you want to remember that your family, your friends are your first therapist, right? So they're the first people that you want to open up to. And even with the stigma, they're the first people that will listen to you and care the most about you because you're the ones that are in your lives immediately at the time. And hopefully, they're the ones who will also steer you towards help from a mental health perspective. And another one that we also don't think about is in a new place, a new country, you don't know very much. So the first thing you do besides learn as much as you can is look for someone else who does know more, right? So look, you're not the first immigrant that has come to this country. So look for mentorship in anything you're doing, right? If it's medicine, then it's medicine. If it's engineering, it's engineering. I know those are the stereotypes, but like honestly, that's where you're gonna find a lot of Nigerians at. So look for people in those disciplines that are Nigerian, that have been through the process, gone through difficult things. Those are all things that will help out. And luckily, like I said before, in the diaspora, there's a lot of Nigerians. I'm not sure the exact number of Nigerians in the US, but it's a lot. So they can kind of show you things that will help and they can guide you towards additional opportunities. And like I said, in part of the reason mentorship is important is because whether you're intelligent or experienced, the problem is the new place, new system, new approach. You don't know the things that you don't know. But those mentors often will, or have thought about and experienced things differently than you have. So part of the solution for the mental health issues is reaching out to people that are like you. And some of these are generic because it's not just a Nigerian specific thing, of course, because we all should do this. Like I said, mental health is multifactorial. Exercise. Who doesn't love the gym? Please go to the gym. Please run, do whatever it is, whatever sport that gets you going. Exercise is always a big one, even really in all aspects of medicine. I know in medicine, The two biggest things I always say as a physician, pretty much there's, like I said, there's no magic pill that solves all issues. The two closest things without literal pills are exercise and lack of smoking. Just don't do those two things, and you're well on your way to living your best life. And of course, getting good sleep always helps with everything as well, but especially mental health. 3 hours of sleep, like you can't really machismo your way through getting 2 hours of sleep a night. Eating well, things that kind of put your mind and body in a place together. Easier said than done. Obviously, the one that comes to mind is something like yoga. Maybe difficult to get a Nigerian immigrant to go to yoga or something like that. But the good thing that kind of connects those is exercise, right? Exercise is there's a lot of like hand-eye coordination. So anything that connects the mind and body better tends to help with mental health. And like I mentioned before, the community and social support, having people in your corner is very, very important. And it's really hard to see this sometimes because it's almost obvious. You just go through life, you get some friends and people that like you and things like that. And but you appreciate it a lot more when you actually go through something that's, like an illness or an issue. And the same thing applies a lot to any mental disorders, maybe even more so than regular medicine. And I know I spent some time not talking well about it, but faith and spirituality often helps a lot of Nigerian men as well because they're very strong believers in whatever the belief is. Most often Christianity and Islam. And they will also have the community affiliated with that faith via churches or mosques. I've given you a few solutions. Unfortunately, I'm going back to the challenges. So there's a very low psychiatrist to population ratio. There's a very low number of Nigerian psychiatrists at baseline for everything. And because some of the best people to understand what other Nigerian men are going through, mm, or other Nigerian men, this leads to a misinterpretation of symptoms when going to other psychiatrists. And then again, like with lack of understanding, you really would like someone who understands you better. So there's a lack of culturally competent providers. Mm. So I remember talking about like what does a, a presentation on Nigerian men's mental health really mean? Are we talking about people who came here when they were much younger? Are we talking about people who came here when they were older? Are we talking about immigrants who came here when they were like in their 30s, their 40s, their 20s, when they were a kid like me? What does that mean? It's a wide variation. So in order to cover that wide variation maximally, it'd be nice to have a wide variation of psychiatrists maximally as well who understand different populations better. Mm. So unfortunately, that's just not the case. In 2010, which sounds long ago, but because it's 2026, but that's not very long at all. Only 16 years ago. 384 Nigeria trained psychiatrists in the US, UK, New Zealand, and Australia. The irony of that is still more than the total number of Nigerian psychiatrists in Nigeria itself. Nigeria has, I believe the last number I saw was actually about 200 psychiatrists in the entire nation. Again, this is a nation that has over 200 million people. And then back to those numbers, only about 2% of all US psychiatrists, broadly speaking, are Black. There are others that they're ethnically Nigerian, but they're not necessarily, say, Nigerian trained. So they didn't train psychiatry in Nigeria. So that falls between 300 to 500, which is not very much. And there's already a mental health population or mental health physician shortage at baseline. Other thing to talk about is the symptoms that Nigerian men may express. So when they are going through things like depression, they may think of it more like stress than depression. Anxiety just thought of as overthinking. PTSD, because of kind of some of the very rough conditions in Nigeria itself, and just because of the kind of, again, that kind of stoicism mentality, they might just consider this a normal hardship when it's very much not. And substance use, which is unfortunately very universal. Not really even a Nigerian man thing. It's just well, life is hard. Let's find a way to cope with it via substances, typically alcohol, because that's ubiquitous. And I've mentioned some numbers, but there's very little research. I'll try to go over some of the numbers again. So let's look at psychosis. So psychosis is one of the first things people think of when they think of like mental health or psychiatrists. They're thinking of schizophrenia, but schizophrenia is actually a pretty small subpopulation of mental health across the board. And then psychosis itself is not schizophrenia. Psychosis is a modifier term, meaning that you can have a lot of conditions with psychosis. So psychosis is typically thought of as things like audio and visual hallucinations, but it can also include delusions and not thinking properly, kind of like not interpreting the world properly as everyone else is or should. But so schizophrenic prevalence is not just in immigrants, but also in their offspring. Risks often being the second and third generation of immigrants. One of the better studies done on this showed a two times higher risk of schizophrenia second generation immigrants versus non-immigrants. Like I mentioned, there are very few studies that look at immigrants in general, but specify the Nigerian population. And most of the studies have very small sample sizes and heterogeneity between studies, which means there's they're not very the the how do I put this? There's a lot of differences between the studies, so there is not a very like homogeneous population in the study. So it's hard to tease out what really shows what. So even with these few studies, we can see that the overall takeaway is that there are a lot of risk factors, multi-generational risk factors beyond just the initial migration experience. Um, and then, because we all love numbers, one study in migrants, which is still now keep in mind this is not Nigerian immigrants specifically, but migrants broadly speaking. This is a meta-analysis, which is one of the best kind of studies because it has the best evidence type. Shows roughly 43% for anxiety, 49.5% for depression, 40.8% for PTSD. Those are the most common diagnoses, by the way, for mental health in migrants. So roughly 40 to 50%. Um, but keep in mind, this is just a brief overview, and the real numbers are unknown because there are not many Nigerians, men in particular, that would even show up to a doctor's office and ask about mental health stuff. So the few studies that do talk about that show that 30 to 40% of the Nigerian men show up with some level of anxiety, depression, or PTSD. And those are the most common diagnoses. I suspect, because I couldn't really find very many studies on this, I suspect that other diagnoses are either the symptoms are not brought up because they don't want to talk about it. So, for example, something like psychosis, something like hearing voices, seeing things, they're doing their best to not bring it up because of stigma, whether stigma originating from back home or just stigma in even here. Like I said, I talked about some of those visa issues. Um, so if we talk about those numbers now, what doesn't work for a Nigerian man? If you start talking about emotional vulnerability things early, or ignoring cultural beliefs, if you kind of start the conversation by Xing out a lot of their thought process or how they think the the frame of the world is, if you start by attacking that, that's terrible. And of course, if you start by talking about it from a medical perspective excessively, that's also terrible. The first thing that they're gonna do is shut you out. Now, to be fair, most of this applies to broadly, like most people in a mental health perspective, broadly speaking. Like I said before, a lot of Nigerian men are very religious, so you can't dismiss religion outright. So the general approach is pretty similar to the general approach for most patients. So CBT is something we call cognitive behavioral therapy. And then, of course, family. Nigerians are very family oriented, and talk therapy. So as mentioned before, your first therapist are your friends and family if you open up to them for Nigerian men. And then there are a few directors of Nigerian American therapists and counselors in the US. There's still not very many of them, but there are a handful of them. And then this part's kind of difficult, but if you're able to allow them, if they're, or rather the other way around, if they will allow you to, if they will allow you to involve the church and their friends in other aspects of their community, that's very useful. Again, this is just kind of the beginning approach. And this is therapy. This is really just getting the guy to open up, to allow themselves to talk freely. So therapy is important for most things, but for any mental health issues with Nigerian men, very, very important. And then, of course, the big one, because nobody wants to think about taking any medications. All right, so first and foremost, nothing in psychiatry is ever mandatory. Even if a pill or antidepressant or whatever it is recommended, it's never forced. There's always an option to say no. Now, there's a wide variety of medications from antidepressants to antipsychotics to mood stabilizers. Mm, that being said, it's very rare that, like I said, there are very few magic pills that'll just fix the issue. So therefore, it's often one medication will not simply be enough. So we're probably going to do some combination of therapy. And if so, for example, someone with depression, uh, first first line therapy, second line therapy, third line medication. So we may treat them with an antidepressant, but at the same time, therapy must always be ongoing. If they have a family involvement is always good. It's not just a Nigerian man thing. This is broadly speaking as well. And a combination is typically ideal. In fact, not a combination of medications because we don't want to just kind of keep throwing medications at someone and seeing how many, we get them to take. We're not doing that unless they have an issue where that is indicated. Mm. And then with a lot of the medications, obviously, like every medication comes with its own side effect and risk, which should be well explained by your psychiatrist. The side effects tend to be drowsiness and sexual dysfunction. The medications with the worst side effects tend to be last line, right? In um, all mental health, in all psychiatry, but in all medicine overall, there's always your first line treatment, second line treatment, third line, and it just keeps going until we have the very last thing that we can try. But there's a reason it's the very last thing, right? That has the worst side effects, has the worst prognosis or the worst outcomes, or we just don't want to use it because the risk benefit is not always great. So, for example, with depression, or excuse me, with psychosis, there are various treatment resistant levels of psychosis, and one of our big we call it a big gun is something called clozapine, but it also has some of the worst side effects of the antipsychotics. But that's okay because we have a lot of antipsychotics we will try before we even get to that. So the medications with the worst side effects, like I said, tend to be last line. So first, second, third approach, third level medications, they're all relatively safe and very well studied, right? Your basic antidepressants, I'm sure you guys have heard of Zoloft which is sertraline, mirtazapine, Wellbutrin. A lot of those are very well studied. And then there's medications after that. And then there are a few combinations that have their own things that are better. Um, but before any medications are started, because as we all know, everyone's anti-medication. Even as a psychiatrist, sounds ironic, but I'm also anti, in some ways, I'm anti-medication in the sense that I'm anti-polypharmacy, which is a phrase that's used nowadays to describe when one patient is on a lot of medications. So part of being a psychiatrist actually is finding a way to reduce the number of medications the patient is on as much as you can, so that to get the maximum outcome, the best outcome for the least input of medications, if that makes sense. So best output for least input. But before any of that, all of these should be discussed along with the psychiatrist. There's a reason psychiatrists tend to talk the most to patients, not just because of the therapeutic component and getting to know the patient, but simply because, like there's a lot that go on with this medication. So psychiatric medications are medications that probably have the most leeway to be adjusted as far as dosages and combinations. So your psychiatrist should not just be sitting down and saying, "Hey, I'm just going to start you on this and this." They can say that, but they should talk about why they want to do it and why it'll be useful and why they want to combine certain things. Mm. And I've said a lot about psychiatrists because I'm a psychiatrist, but therapists and counselors also have a lot of involvement. Most psychiatrists are able to counsel and be counselors to some level, but if some people just need people to talk to, and that's where a lot of therapists and counselors come in, and we can, in some cases, like, we can just do it with the medications, right? Issues are still real, like stresses are still real. So in some cases, all that's really needed is to find a way to address the stressors and have a safe space to talk about the issues. And that's if that's the treatment, then that's the treatment. We don't need to do more than that. We want to do the least for the most. So barriers, again, in Nigerian men, therapy is for weak people. Men should handle their problems, again, that like excessive machismo, masculinity, excessive stoicism. There's always a time and a place for stoicism in the sense that life is not easy, right? Life is hard, so you have to be able to, for lack of a better term, like get up and like handle issues when necessary. But there's some things that are not addressed simply just that way. Mm. And then we talk about spirituality and religion. So don't, as a psychiatrist or therapist or counselor, don't compete with it because you won't win. Not with Nigerian men, that's for sure. You have exactly a 0% chance of winning if you're saying you're gonna go my way or the religious way. They're gonna go the religious way every single time. Mhm. And then Nigerian men are very like, goal oriented. So with therapy, it's not just a let's talk about your feelings about these things. Yes, that's important and that's good, right? You want to get people to open up and be willing to tell you about themselves and about their issues, but always remember that it should be goal oriented. There should always be a point to the therapy. So you should always try to have practical outcomes. And speaking of practical outcomes, when specific issues are come up, those are the issues that you want to like address. So in this case, sleep, right? So you want to talk to them about how we're going to improve your sleep. If they're saying, "Oh, I'm getting like 4 hours a night," then the goal is okay. We're gonna try to get you consistently get 6 hours a night, something like that. And then stress. What does stress mean? How does stress manifest? We talked about some of the physical symptoms that come with the stress. Or work performance, if they feel like their performance at work is going down because of some of their symptoms. You want to frame it as really being the best version of themselves, because if you don't frame it as something in that regard, it'll be disregarded. right? So you want to frame it as optimizing themselves, as mental discipline, as resilience training. Mm. So otherwise, it will be a lot more difficult to get a Nigerian man to trust you. And it will be difficult at baseline, if I'm being honest with you. All right, so I'm just going to go through a few cases. Um, I read it out loud. Okay, so Chidi is a 42-year-old structural engineer who moved from Lagos to Houston 5 years ago. Back home, he was the shining star of his family, the one who successfully Japad. Japad is a phrase that often means like left Nigeria, and now sends money back every month for his younger sister's university fees and his mom's blood pressure medications. So everyone in his WhatsApp groups, Chidi is living the dream. However, over the last 6 months, Chidi has started feeling like a stranger in his own body. He doesn't feel sad in the way he sees people cry in movies. Instead, he feels a heavy, constant fatigue that no amount of sleep can fix. He often tells his wife that he feels a strange heat crawl in his head and a tightness in his chest that makes him worry he's having heart problems. At work, he's increasingly irritable. A small mistake by a junior colleague, which he used to handle with a joke, now makes now makes him ball with a quiet, cheeky anger. When he gets home, he no longer plays with his children. He just sits in front of the TV, stares at the screen without actually watching it. He started withdrawing from his church community, making excuses that he is too busy with overtime because he feels a deep sense of shame. He thinks to himself, a man like me should not be feeling like this. I have a good job and a family. Am I being ungrateful to God? Is this a spiritual attack or am I just becoming weak? Despite his physical strength, Chidi feels like he's carrying a bag of cement on his shoulders every single day. He continues to send money home and smile for the camera during video calls, but internally he feels empty, as if the engine that drives him has finally run out of oil. So my approach as a psychiatrist be thinking about what exactly he's complaining about. So he talks about because of the stigma against the mental weakness component, they're typically going to present with physical complaints. So I mentioned like the heat in the head, crawling sensations, which is known as formication, or heaviness. In a Nigerian context, these are often direct expressions of severe anxiety or major depression. So those are the two kind of things you want to be thinking about. What does this really mean from a diagnostic perspective? That being said, just because we're psychiatrists, we're still medical doctors, and weird feelings like that can occur like medically as well. So one of the first things we do as psychiatrists is to rule out actual medical issues. Right? It's very possible to like for something like this to also be a real medical issue. So when I think about any mimics like with these symptoms, so if you think about things like thyroid issues, vitamins, vitamin could be deficiency, could be excessive intake, cardiovascular issues, neurological issues. The human body is weird, so there's a lot of different things to think about. And unfortunately, diagnoses are unending. But that's for me to worry about. Um, so then the management strategy from my perspective is reframing how he's thinking. And these are the kind of topics that we want to talk to him about. So we want to address the guilt, acknowledge that he's under more pressure than his American peers at baseline. Everyone has pressure, but some of the pressures a lot of immigrants face are just kind of just a little different. Like I said, this presentation is specifically for Nigerian men, but the truth is this applies broadly to a lot of immigrants at baseline. So almost everything I talked about works, I would argue, for most immigrants, most immigrant men anyway. So there are some things I may not know, in which case I may talk with a specialist about. There may be some neurological things I'm thinking about, so I would call maybe a neurologist and consult them. Mm. If the patient thinks it's a spiritual attack, I wouldn't argue that point, whether I disagree or not, which I would disagree. So I would probably talk to him about his spiritual life, um, see if he's okay with me talking to his pastor or imam if I have time. Mm. So the general kind of thought about this is thinking about like I will handle the physical and chemical side of the brain, so you have the strength to pray and do the religious aspect that you feel you need to do. All right, all right. So quick question, I'll answer it because I know you guys are all muted. Chidi is a hardworking man, recently moved abroad. He's always tired, feels a strange heat in his head, and gets angry easily at work. He thinks he's just stressed or experiencing a spiritual attack. Which of the following is the most likely reason she is feeling this way? He's just weak. B, he's not praying hard enough. C, he's experiencing depression, which can feel like physical pain or anger in man. Or D, he's just ungrateful for the success he got. So, I mean, obviously the answer is C. I'm not going to ask you guys board exam questions. All right. I hope you guys aren't tired of hearing my voice because I'm getting kind of tired of hearing my voice. But Tunde is a 38-year-old pharmacist who moved from Abuja to Chicago 3 years ago. On the outside, Tunde looks like a man who has arrived. He has a steady job, a nice car, and he never misses a Sunday at church. But inside, Tunde feels like a motor that is constantly running at full speed but going nowhere. For Tunde, this doesn't feel like fear. It feels like the weight of tomorrow. Every morning before he even opens his eyes, his mind is already racing. He worries about his mortgage. He worries about whether his children are losing their Nigerian culture in American schools. He worries about the security situation back home and if the money he sent to his brother for the new house is being used correctly. Even when things are going well, Tunde is waiting for the other shoe to drop. He tells his friends, in this life you have to be vigilant, but his vigilance has become a prison. Physically, Tunde is exhausted. He has developed chronic muscle tension. His shoulders are always pulled up to his ears and his neck feels like a stiff board. He has running stomach, IBS issues almost every morning before work, which he blames on the heavy American food. Though it happens even when he eats home cooked rice, he finds it impossible to sit still. If he isn't working, he feels guilty as if he's wasting time that shouldn't be spent secure in the future. When his wife tries to talk to him, he's often short with her. He isn't trying to be unkind, but his mind is so crowded with what if scenarios that he has no room left for conversation. He struggles to sleep because as soon as the house is quiet, the voices of responsibility start shouting in his head. All right. So the approach is Nigerian men typically view anxiety as like a rational response to a difficult world rather than a disorder. You must look for signs of a nervous system that cannot power down. Identify hyperactivity. Ask about the running stomach, which is likely IBS. IBS is triggered by anxiety and it's typically like it's just gonna go into the bathroom because of excessive anxiety and your GI system kind of going running overboard. So ask about tension, headaches, pounding heart. These may be the only symptoms a patient will volunteer. So the way I wrote the vignettes makes it obvious, but remember these patients come in with very subtle symptoms. They're not gonna give you these full paragraphs. It's like an organization to it. They're gonna come with very subtle things. In order to tease the rest out, you have to ask a lot of good questions and get them to trust you to be able to answer. All right. That's the hyperactivity. And then think about the vigilance. Instead of do you worry, ask do you always feel like you always have to be on your guard for your family's future? Because if you ask very straightforward questions, they'll give you very straightforward answers from their perspective. Do you worry? No. Is it hard for you to truly rest because your mind is always calculating the next move? Hmm. So the strategy is to rule out medical issues, like I said, always. You'd be surprised. So you want to ask him about caffeine, get labs for his thyroid, see if he has any other medical issues that he may himself may not be aware of, sleep apnea, arrhythmias, so anything cardiovascular. And then, like I said, when you're looking at problems, you want to be very pragmatic. Okay, so think about make him think because a lot of this is not just telling. You want the patient to figure it out themselves on some level, right? Especially when it comes to therapy. Anyone can tell anyone, hey, this is how you solve your problem. But what you really want to do is to get them to tell you how to solve their problem. So we'll think about productive versus unproductive things. Things he can control versus he can't, right? So what does he have in his life that he can do? Like I said, stresses are still real. That's just because I'm a psychiatrist does not mean that your stresses are not real. Your life is your life. There are things that occur. If you have a car that breaks down all the time, like that's a real thing. It's not something a medication is going to go away, take away. That is a stressor. Um, that is something that will give you anxiety. So what can he control today and how would he approach that, right? So you want something that's pragmatic so you can think about the actual steps to fix the problem. Step one, step two, step three. And then if those steps don't work, what's plan B versus things that he can't. So if he's stressed about things that occur in Nigeria, you know, is that something that he can actually do anything about? He's in Chicago right now. All right. So kind of a quick summary of that. So Tunde is a successful professional who always feels like his mind is racing while he's worrying about his mortgage, his children, and his family back home. He has a very stiff neck, a running stomach every morning, and finds it impossible to sit still and relax. What is the most likely reason for Tunde's physical problems? A, he's eating too much spicy Nigerian food. B, he's naturally a serious man. This is just a personality. C, he has generalized anxiety disorder, where constant worry causes the body to stay in high gear. Or D, he's lazy and needs to work hard to solve his problems. Well, we know he's not lazy, so the answer, of course, is C. He has generalized anxiety disorder, where he kind of just stays in an anxious mode all the time. This applies to everything. Before we go on to the next case, one thing about a lot of mental health issues is they don't just stay in their own lane. They tend to affect every aspect of your life because they're ever present. So one big thing psychiatrists do actually when they treat these symptoms is we fortunately increase, or at least our goal is increase the quality of life of the individual. It's not just like a one time thing. Like, okay, this is the issue, we handle it. This is gonna bleed into every aspect of your life for every Nigerian man that may be hearing this. Then case three, Emeka is a 45-year-old man living in Chicago who left Nigeria 10 years ago. In Nigeria, Emeka worked as a driver for a high-ranking official and survived a violent carjacking where he was held at gunpoint for several hours. When he first arrived in Canada, he told, oh, well, when he first arrived in Chicago, my mistake, he told himself, that is in the past. I am in a safe country now. I must focus on my new life. However, the past has a way of leaking into his present. Even though he is thousands of miles away from that road in Lagos, Emeka lives in a state of high alert. When he is driving his taxi in Chicago, a car backfiring or a sudden loud shout from the street makes his heart leap out of his chest. For a split second, he is not in Canada anymore. He's back in that car, feeling the cold metal against his head. His hands start to shake, and he breaks out in a cold sweat. At night, the safe darkness of his bedroom feels dangerous. He has vivid nightmares that feel so real he wakes up gasping for air. Because of this, he avoids sleep, often staying up till 3 a.m. watching the news or pacing the living room. When his wife asks why he's restless, he snaps at her, "You don't understand the world. I am just being careful." So, as always, think about all the different psychiatric diagnoses Emeka could have and rule out any medical issues. So you already know the drill by now: thyroid, cardiovascular, and then anything else. Okay, and then think about his behavior. Is he currently even still in a new place, avoiding certain roads? You want to ask about why or why he thinks he is. Has he stopped calling home to Nigeria? Mm. And then you want to think and talk about where he talks about hyperarousal. Do you always feel like you're on guard, even in your own home? When you hear a loud noise, does your body react before your mind knows what happened and then why? You want to ask about nightmares or thoughts that he has that he cannot control. So the question, Emeka survived a scary event many years ago in Nigeria. Even though he is now safe in Canada, he still jumps at loud noises, has bad moves off the event playing in his head at night, and feels numb or disconnected from his family. What is the most likely reason Emeka is still struggling? A, he's not brave. Well, probably not. B, he's choosing his own path instead of moving it on. Or C, he has PTSD where his brain still thinks he's in danger. Or D, he's forgotten his culture and needs to go back home. So of course, this is an example of PTSD. One thing you might know from these questions stems is like a lot of them don't seem that crazy or unique. That's because at the end of the day, I mean, what is it now? 6 billion? I think it's pushing 7 billion people on the earth. It's really hard to say everyone wants to, try to be unique and like special, but we all kind of experience a lot of the same things. So PTSD may just be a specifically different circumstance in one part of the world than it is in a different part of the world. So in this case, the PTSD event in Nigeria still correlates very directly with, even if someone was born here, a PTSD event here. They just, one just happens to be in a different place with a different kind of person, and but it's still the same mental health issue that like we're still humans, we all experience the same thing. All right, I believe this is the last case. I hope so, because I'm talking a lot and my mouth is dry. Segun is a 29-year-old software developer who moved from Lagos to London 2 years ago. Segun was always known as the bright boy of the family, quiet, hardworking, and deeply religious. However, over the last 3 months, his behavior has taken a sharp and frightening turn. It began with Segun becoming extremely private. He started covering the webcam on his laptop with black tape and unplugging the television at night. When his flatmate asked why, Segun whispered that the authorities were using the devices to monitor his thoughts because he had developed a secret code in the banking software he was writing. Soon, Segun stopped going to work entirely. He spent all day in his room, talking loudly to people who were not there. When his mother called from Nigeria, he told her, Mama, don't use the phone. The neighbors are using the radio waves to beam messages into my brain. He claimed he could hear the voice of an old headmaster from his primary school in Oyo State, constantly insulting him and telling him he was a failure. To Segun, these voices were as real and clear as the person standing right next to him. His hygiene begins to suffer, and he often wanders the streets of London for hours, looking over his shoulder. He told a friend at church that he was a special messenger sent to protect the Nigerian diaspora from a spiritual conspiracy. When the pastor tried to pray for him, Segun became agitated and suspicious, accusing the pastor of being in on the plot. So this is an interesting case. I haven't really dived into this, but a lot of psychotic symptoms, there's a lot of them that take place and have what we call a religious perseveration. In other words, the psychotic symptoms are not necessarily secondary to religion, but they take religious overtones, right? So often patients thinking or some variation of them being like some kind of religious leader or being God or the devil or some variation of those kinds of things. Mm. That's why it can be kind of tough to integrate their religious background to treatment. You should still, of course, try. Sorry, I know some of you sent some messages in the chat. I'll try to address those after these cases. He has not been difficult and hasn't joined a cult. His brain is just playing tricks on him, making it impossible for him to tell what's real and what's a hallucination. He feels the mix of grand importance and terrifying persecution, while his family back home may be scared that this is a spiritual attack or the result of quote unquote juju from a jealous rival. Segun is actually experiencing a medical emergency in his brain. Ask about hearing thoughts or voices talking when no one is there. In African populations, these voices are often perceived as coming from outside the head and are frequently critical or commanding. The quote unquote madness stigma. So I mentioned this at the beginning of the presentation. So in I can only really speak to Nigeria, but often when people have things like schizophrenia or just psychotic symptoms in general, it's considered madness, quote unquote madness is what it's called. But because of if you think about that, or if something like that is only considered madness, all that means is a lot of people tend to isolate away from them instead of trying to treat it like it's something that can actually be treated, which you can. In fact, one of my first month as an intern here, I saw a lot of people with psychotic symptoms go from very psychotic to baseline just over the course of a few weeks, and taking some antipsychotics and a couple sessions of therapy, some talking, so you can like the right treatment with the right people and the right social support, you can make a massive difference. So in this patient, for something like this psychotic symptoms, most in this vignette is most likely just schizophrenia. I didn't give a timeline, so it'll be there's some differentials on there, but you would want to treat him with antipsychotics. And we just talked about his family. So his family is pretty far away, which makes it kind of difficult. But family input and again, I'm like I said, that social support, well, family help and support is really, really important, especially for something like schizophrenia or yes, for schizophrenia, which is a high relapse rate. Having the people around them being very supportive and understanding the treatment and symptoms and being on the kind of on the watch for any changes and making sure the patient's taking their medication in a timely manner. It's really important, really critical. All right. So our question, I already kind of addressed everything here, and I want to get to your questions. So I'm actually just gonna ignore this. I just read the vignette. So like I talked about it already, but he's experiencing psychosis. Like I said, I wouldn't officially diagnose him with schizophrenia because I don't have the timeline and other things. So in general, things to watch out for, especially spouses who are going to be the ones that kind of note the mental health symptoms first. So you want to like your husbands the best, honestly. Um, in many cases, more than their families, unless of course the families are kind of they're ever present. So you want to look for mood and emotional changes. So persistent sadness, low mood, irritability, anger outbursts that are not typical of well this guy. Um, and it's some things that feel like emotional numbness or detachment that they typically don't have. Any cognitive changes, right? A lot of Nigerians pride themselves, when applicable, on being very bright and concentrating very well. So if that's been changing over time, or they're missing a lot more things than they would, or they're being a lot more indecisive, or they're thinking negatively, most Nigerians are very optimistic that things will work out, and they often work very hard to do so. So any cognitive changes in this regard. Sleep disturbances, of course, I mentioned all of this before about insomnia, trouble staying asleep, getting up a lot in the middle of the night. If they're sleeping too much, that's very uncommon. Most Nigerians are not trying to sleep a lot, so always trying to do more and more. Or if you feel like they're not getting that much sleep and they seem to be getting like sleepy in the day, so the sleep that they are getting is not very restorative. Of course, appetite. So if they have loss of appetite, weight changes, they're talking about feeling low or have low energy, tired all the time, those kinds of things. All right. Okay. Any questions? Let me look at what you guys said in the chat. Okay. Um, really quickly before I take any question in the chat. So the first question, or excuse me, before I take any questions out loud, the first question in the chat is: if you have a patient that has severe anxiety and depression, would you attempt treating one over the other, or would you prescribe medication that targets one and see if the symptoms decrease for the other? Hope I didn't mumble too much over there. Okay, so this is a good question. Basically, she's asking for a patient that has severe anxiety and depression. So those are two different symptoms, right? Would you attempt treating one over the other? Like, would I pick one to treat over the other? That's a good question. This is a little bit of a cop out because I get to cheat here, but luckily, the best treatments for depression also treat anxiety. So I wouldn't have to choose. My first line treatment, you guys already heard of it, would probably be Zoloft, or the brand generic name is sertraline. It has very low adverse reactions and has been very well studied. So the good news is Zoloft hits depression and anxiety very well. So I would, if I had to like prioritize one, I would probably prioritize the depression, just because depression tends to impact the what one is like the productivity of one's life. However, keep in mind, I'm biased. Even though I said all these things about Nigerian man, I'm a Nigerian man. So all those things that I said, whether you think it's positive or negative, all apply to me for the most part. Like, no, I didn't make things up. I just like a lot of it I've seen myself as well. But I'd probably approach depression the most, especially in therapy, mostly so that they can go back to being productive in their lives, to be honest. But like I said, I really would not have to choose. I get to kind of hit both at the same time from a medication standpoint. Okay. All right. That's the only question I see on here. Um, all right. Any questions? I don't think we have any other questions, so thank you all for being present for the presentation.
Dr. Ezeokoli, have you answered the second question?
Oh no, there was no second question. I just saw two notifications in the chat. Are there other
Okay.
chats that? Oh, okay, never mind. I lied. I see the other question now. Okay, so if having anxiety and depression leads to other medical issues, do you refer patients out for those issues as well, or just focus on the depression? Okay, that's a good question. That's like a CL question. All right, so this comes down to two things. We'd have to think about whether that symptom is an isolated medical issue, right? Something that could be treated medically and like on its own, which it probably would not be. So let me think of it like I'll come with a scenario. So let's say excessive anxiety leads to new onset arrhythmia, which is a fancy way of saying like your heart skips a beat or the way your heart normally beats, there's an issue with it. Um, So if it's an arrhythmia that's fixable with like a simple antiarrhythmic medication, I would probably send them to a cardiologist just because I can fix the arrhythmia immediately. And they'd probably prescribe something that blocks the rate or rhythm. So to get them back to normal, just because that's something that's a little bit more dangerous, right? Because and then I start treating their depression. Though in reality, I'm also able to do both. It's not a, right, I can treat their depression and talk to the cardiologist as well. Or in some cases, I'm not sure, and I'll just pick up the phone and say, "Hey, Mr. Cardiologist, this is my patient. This is what's going on. This is what I'm thinking. What are you thinking?" Right? That's why we have consults in medication in medicine for a reason, to kind of pick each other's brains. All right. Another question is for schizophrenia, can it be cured with medication? All right. So, like I said, magic pills or lack thereof. Yes and no. Cured is a strong word. The problem with schizophrenia is, and I didn't go into this because this was not really a medical presentation. I did a lot more of kind of the therapy-ish side. So can schizophrenic patients be cured with medication? Like I said, no magic pill. So we have what we call first line treatments, second line treatments, and third line treatments, and so on. So we tried the first line treatment with is always almost always medication. Unfortunately, schizophrenia is not one of those things that you can treat with like just talking. I can't just sit the patient down, me sit down, and then we just talk and they'll get better over time, like twice a week. That can help, right? Because that can help orient them and help their approach to life. But medications are almost always indicated. I know I talked about not kind of throwing pills at everyone. I'm not gonna lie, schizophrenia is one of those disorders that you will have to throw pills at people. You can't force anything on anyone, but you definitely like often. So I'll say it like this: often, what's gonna happen with schizophrenia is the patient will get what we call an antipsychotic, and they will like the schizophrenia, which is gonna manifest as typically visual auditory and visual hallucinations, and some delusions. Those symptoms will typically go down and they will start thinking clearer and be able to communicate better. Not always normally, but they'll start communicating clearer and you may kind of start being able to talk to the patient more rationally and explain yourself better to the patient, and the patient will be able to explain themselves better to you as well, and often be fully engaged with treatment. But not always. There are times where there's some patients that they're not, that doesn't really help. So at that point, we'd move on to the second tier of medications and use that. And then sometimes a third tier, sometimes a fourth tier. Right now, there's some newer treatment styles that are coming on. There's a lot more potential for interventional psychiatry, and that's something I'm still learning myself. So to answer your question, cured, not always. There are some patients that are very treatment resistant where we've gone up. Like I talk about some of those medications that are like the big guns that we try not to use. Some of them we have to use. We don't have a choice, right? So we go straight to the clozapine. Clozapine is a little more dangerous in the sense like the side effects are bad, and I would not even be giving clozapine without consulting the cardiologist probably, just to make sure they're aware and like they're on the side and seeing the patient as well. And I'd be making sure I'm seeing that patient every week because the side effects, like I mentioned, are not great for the heart. So, but even with that, the patient may still be treatment resistant, meaning their schizophrenic symptoms do not alleviate significantly. But sometimes it helps. Clozapine works a lot also. So it is a great drug, even though I'm saying, don't be too scared of it. It's just not the first drug I give. But at the end of the day, it's unfortunately it's in medicine, it's an art. There's no, like I said, there's no magic pills. We try with the lowest input for the most output, and then we keep increasing the input and then seeing what output we get with each thing. Like I said, what's really important is your psychiatrist should be talking to you a lot about all this. There's a reason psychiatrists tend to spend more time with their patients because it's a lot going on, and there's a lot more human medicine, right? This is different because therapy is a little different, but there's a reason like a lot of patients jump around and see different therapists before they meet a therapist they like and want to stick with. It's not the exact same, but that applies more to psychiatry than a lot of other things. Like if you go to a surgeon like to fix a bone, chances are almost every surgeon you see can do that, and you're not going to jump around. First surgeon you see, you broke your tibia, surgeon's going to come in and fix your tibia, and they're going to do it almost as well as every other surgeon out there. Psychiatrists, you may not like your psychiatrist, and therapy is part of your treatment, so you may want to go see a different one. That happens less in other medical specialties. So, all right. Yeah, okay. I think that's it. I have to go see a patient pretty soon, so I'm gonna have to head out. All right. Thank you all.